So I'm recording and your time, if you're ready, timer starts. And here is your question. And you know, in these days, there'll be no patient, so you have to tell me in a narrative way. This is what we're practicing.
Yes, ma'am.
Yes. Right. If you have read and understood, can you begin your examination?
Right. Thank you, ma'am. So first, I will wash my hands and
Yes.
on the the possible appropriate, and I introduce myself. So, Dr. Joshua, one of the surgical examinees taking care of you today. May I please confirm your name and date of birth, please?
So you'll enter, you'll greet the examiner, and then according to the stem which was written outside on the page, you will confirm the name and age of the patient, and then
All right.
yes,
And then I'll explain the after confirming the name and date of birth.
yes,
So today I will perform cerebellum examination. It's to examine your balance and coordination
yes.
in your body. So are you happy to proceed with this examination?
So you'll explain the procedure that you are going to
Procedure.
be
Yeah.
carried
So
out
this
to the
this will
patient. Yes.
okay.
Next,
So
please.
this
Yes.
will involve me feeling for your arms and your also like to look for your movements of your eyes and also the gate, right? And then proceed with the examination.
Yes. So
Okay.
after taking the
So
consent, yes, how would you begin your
so are you?
examination? Yes.
So first, I would like to ask for any pain or any discomfort prior to the examination. And if there's none, all right, I'll inform the patient if there's any discomfort or
Very
pain
good.
throughout
Yes.
the examination.
Yes.
Feel free to interrupt me. Okay. So first, I will walk the patient's gait. I'll instruct the patient. So kindly walk towards the wall. Okay, and then turn,
Okay.
and then walk back towards me with your one foot in front of the other. This time I'm assessing the tandem gait or the heel to toe. And then
Yes.
next, please walk in your tiptoes and then walk in your heels. Okay, and then I would look for any abnormality in the gait, like an for instance. I would like to proceed the Romberg's test.
Yes.
Although this is not a test for the cerebellum, I will just try to rule out other possibilities. So I'll inform the patient, please stand up in front of me and feet um, close to each other with your arms on the side. And I
Yes.
would like you to close your eyes and try to stand still. Don't worry if you feel unsteady. I'm here in your side and we'll try to catch you if you fall. All right. And then next is the assessment of the speech. I would
Okay.
like you to repeat after me. So I will tell you words or phrases. First would be British Constitution.
Yes.
Then
Okay.
second, can you repeat baby hippopotamus? And then this time I'm looking for a slurring speech or scanning speech. Um, Next, I would like to assess your eyes. Um, First, I would like you to make sure to follow my finger, all right? And then with your head still, okay? So I'll do the like the H test while asking the patient if there's any pain or discomfort or observing for any nystagmus or impairment with the smooth pursuit. And also we'll try to look for any problems with the saccades or whatnot. Then after that, I would like to examine your arms, if that's okay. So first, I start with the assessment of the tone. So I will tell the patient to relax, and then I'll do some floppy movements of your arms. And then after assessment of the tone, I'll assess the coordination by doing the finger to nose test. So here's my finger, and then I want your index finger and your left hand to touch my index finger. All right, then touch your nose, and then touch my finger again, and then keep going. All right, and then I want you to repeat that on the other arm, other hand.
Good.
Okay, so I'm looking for undershooting, overshooting, testing for dysmetria. Next is I would like to assess for evidence of dysdiadochokinesia. So I will ask the
Yes.
patient to put your palms together like this. So one hand on top of the other. All right. And then I want you to flip back the top hand and then bring it back again, then as quickly as possible. And then I
Okay.
want you to repeat it on the other hand. So as quickly as possible.
Yes.
And then next, I would like to assess for rebound phenomenon. And then I'll ask the patient, can you please raise your arms, try to straighten and keep it up as we go through with the examination. And then I'll try to push it downwards. And I just want you to keep your arms up. Okay. And then if there's absence of rebound phenomenon, it's more likely a cerebellar problem. If there's exaggeration, more likely a spastic problem. Next, I would like to move on with the assessment of your leg, if that's okay. I'll first assess the tone. So please relax your legs for me, and then I'll make some fluffy movements, if that's okay. Right. And then next, I would like to assess the knee-jerk reflex while the patient's still in a sitting position, and look for any.
Okay. Can you please present your case now?
I'm sorry, come again, ma'am.
Can you please present your case now?
All right. So today I examined a 49-year-old male, referred by the resident to rule out possibility of cerebellar damage.
Yes.
And on my examination, there's no abnormalities with the gait. The Romberg's test is normal. There's no scanning, speech, or slurring of speech or staccato speech, and the no abnormality in eye movement, normal saccade, and smooth pursuit, and
So
also
what is your
the
differential
tone in the
diagnosis?
upper and lower limb. For this patient, uh, strong hoarding disorder. My differential diagnosis could be a cerebellar
Yes.
atrophy, or also cerebellar infarct, for instance.
Yes. Yes.
Um,
What else could there
and
be? Because
also
it's differential diagnosis, so you have to tell me 3, 4. There could be
and
any.
cerebellar,
Yes.
cerebellar, okay, cerebellar
Tumor.
neoplasm, and
Okay.
also
Can you name few tumors which are found or in the
section,
posterior fossa tumor, in the posterior fossa of the skull?
um, ependymoma, medulloblastoma,
Yes.
uh,
Hemangioblastoma, metastatic tumors,
hemangioblastoma.
dermoid
Yeah.
tumors, etc. Okay. What should be the management of
Okay.
this patient?
The management first, I would like to complete the assessment and order further investigation like full neural exam, or also neuroimaging, and finish with the formal, yeah, neuroimaging.
And treatment should be what?
Treatment, it depends on the case. If it's
If it's tumor, it's surgical.
if it's a more surgical.
Yes.
Extensive care.
Okay, good. So what do you have to, okay, Bell has gone. Now it's the time for the feedback. So what do you all think? How did Dr. Joshua do?
It was very good.
I think it was good.
Yes?
It was really good. The few points first, he did not tell about the exposure and
Yes? And the
Yes.
one.
position, and the
Uh,
position of the patient?
yeah,
The position.
Position of the patient.
Yes.
He missed the cranial nerves examination, the
Yes.
posterior cranial nerve examination, 9th, 10th, 11th, and 12th.
And
Actually,
Yeah, these two.
kind of dependency on that, because in Bazid's notes, it's actually given that you have to examine, because it's a posterior cranial fossa
yes.
tumor. They have
Yes.
asked us to specifically on the question, it is mentioned that we should do the cranial nerve examination. That is why he's mentioned in that. But in this question of MAMS, he's only asked for cerebellar examination. So I
Yes.
think
But you could mention it. You could mention
You
it.
could mention it.
Because we
yeah.
are expecting in the initial tumor also. We don't know it's normal or what.
Yeah.
No.
So if
And
we are
I asked
expecting a
you
tumor,
in the differential diagnosis in particular, so you have to keep that in your mind as well. Yes,
Thank
please
you.
continue.
Ma'am, with the position of the patient, like at the beginning, how would I just, I mean, should I tell the patient should be sitting if I'm assessing the gait first?
yeah, because this test actually has multiple components, so he has to change the position. So I don't think
Okay.
in this we can mention the position.
You
Okay.
can mention as the way you'll go, but like
I think
what I
as and
want.
when we go, we can explain. Yeah.
Yes, because in the beginning, when you sounded little confused, you have to practice in a way that you have to explain everything. You cannot say,
Okay.
can you show me like this? Because there is no patient. You can't ask the patient to do something for you. You will say, I will ask the patient to do this for me, or I'll do this for the patient, and this will be the position of the patient. But like you have to do it quickly. What happened? Bell went, and you were not even were not even done with the examination, right? So this is how it will
Yes.
go in examination. You have to practice doing it quickly and completely. And what you missed, then when I asked you to present your case, then you quickly present your case and then say, if I would have had enough time, I would have done this, or I would have completed my examination with whatever was left, because then it is considered as good as being done. Yes.
Okay. All right. Ma'am, with the exposure, how would I just like, because the patient is in a hospital gown,
Yes.
and I don't think I have to expose.
No, I think when
Okay.
the other part, when you're checking the reflexes,
Yes. Then you
Yeah.
need to
yeah,
expose
you need
the
to.
yes.
Sorry,
Okay. Thank you.
I have comment here. Dr. Joshua is do examination really good and clear in instruction,
Yes.
but I don't know we should check all reflexes in our enough for checking the upper or in lower. And about gait, we should see all type of gait or just in tandem gait and normal gait, stance gait.
I think only abnormal is
Yes,
better
abnormal
because
gait.
we don't have time to just
Yeah.
focus on one piece of information and just spend all the time over there.
True.
Thank you, ma'am.
Stability, he looked. Yes.
I think I'm all over the place in terms of mixing up,
Yes.
giving instruction to the
To the patient.
patient and explaining.
Explaining
I don't
the
know, but
instruction.
yeah,
That's why it's important,
a
Dr.
mix
Joshua, to practice.
too.
I'm actually appreciating you that you came forward and you are at least practicing it. It's better to make mistakes today than to make mistakes on the examination day. So I'll be uploading this, you'll hear this, and then you'll correct yourself.
Yes, ma'am.
Stand in
Thank
front
you.
of the mirror and at least 30 times practice giving instruction to the patient, but you will be telling to a third person, like in a passive form. You're not going to, when you're examining a patient, what happens? The relationship between a doctor and a patient is an active one. Doctor is giving orders to the patient and patient is following it. But in this scenario, you have to explain the examination in a passive form. You are going to convert all your sentences that I will be asking the patient to walk for me, and I will show the patient how I want him to walk. And then when you have to do the heel to toe test, then you will also show to the examiner, or you will explain that I will do the examination like this in front of the patient, and then I will request the patient to follow me or copy me or do the same for me. Because
Okay.
in all the psychological examination, you have to demonstrate to the patient, and then you can ask the patient to follow after you, or yes, to show it to you if they are listening or following or not. So all this you have to do it in a passive language, examination in a passive language. And I'm sure you can do it, because in the examination you were okay, you were mixing, but you were saying it as well, that I will ask the patient to do this. So you can do it. I'm sure you can do it.
Thank you, ma'am. Thank you.
Yes. Anyone else want to add anything, please? Nope. Okay. Timer starts now, and here is your question. Right. If you have read and understood, kindly begin your examination station.
I'll begin the examination by washing my hands.
Yes.
I'll introduce myself to the patient and then confirm the patient's identity.
Yes.
I'll explain what I'm going to do. I'll explain to the patient that for the injury that she's having, I'm going to examine by examining various nerves of the patient. And I will be as gentle as possible. I'll gain the consent, verbal consent of the patient. And then I'll begin my examination. Firstly, I'll assess, as the patient is of trauma, I'll assess the general well-being through the CRISP protocol.
Yes.
If it's all fine, I'll begin my examination of cranial nerves. First, I'll begin with the olfactory nerve. I'll ask the patient to check the smell of vinegar and coffee with the eyes closed, so that if her olfactory nerve is fine, then she can smell and tell the smell of the objects. Then I'll check for the optic nerve. I'll check with the, I'll start with the, I'll ask the patient for the color vision. If Ishihara charts are available, then I'll check the visual acuity by asking the patient to look over Snellen chart from a 6-meter distance. And in this, I'll ask the patient to read the lines from top to bottom, and the line which she can read from the bottom clearly, she should tell. And in this, the numerator of the outcome is the distance, the line which the patient can read, and the denominator is the line which a normal person can read. Then I'll check for the accommodation reflex. Here, I'll ask the patient to look at a distant point and then look immediately at a point at 15 centimeter distance. And during that, I'll check for convergence of the eyes and the constriction of the pupil. Then I'll check for the pupillary reflex by reflecting the light on one side, covering the other. I'll check for the pupil constriction, then constriction of the other eye in consensual reflex, reflecting the light in one eye will constrict the pupil on the other side. Then I will do the confrontation test, asking the patient to sit in front of me. I'll check the field of vision. I'll ask the patient or instruct the patient not to move the head, and I'll ask her to cover her one eye, and I'll cover my opposite eye. And then I'll wiggle my finger in, should be equidistant from both of us, and bring them from outwards inwards. So in this way, I'll check for the visual acuity. And then I'll check with the fundoscopy from a distance for the red reflex, and from nearby for the optic disc, macula, and retinal vessels. Then I'll check for the eye movements of the third, fourth, and sixth cranial nerve. For the this, I will check with asking the patient to sit, and then I'll ask her to follow my finger in an H-shaped manner. If there is any nystagmus or any incoordination of the eye movements, then I'll check for the corresponding nerve involvement. Then I'll check for the trigeminal nerve sensations on the forehead. I'll check for sensations of the ophthalmic branch, on the cheek for the mandibular branch, and on the jaw for the maxillary branch. And reflexes, I'll check the jaw reflex and the corneal reflex. And in the motor part, I'll check for the ask the patient for to clench the teeth, and check the masseter and temporalis muscle bulk, and check for any atrophy. Then I'll test the facial nerve, all the 5 branches. The temporal branch I'll check by asking the patient to raise the eyebrow, and then the zygomatic branch I'll ask her to close the eyes with as much power as possible, and I'll check that against resistance, opening the eyes with my hands. Then I'll check for the the buccal branch by asking the patient to blow out the air in the cheeks and resisting that, and then marginal mandibular by asking the patient to clench the teeth and checking any asymmetry. And the neck cervical branch I'll check by asking the patient to tension the muscles of the neck. Then I'll check the vestibular cochlear nerve by starting with whispering in the patient's ear some number and asking her to repeat that. Then I will check the Weber's, the Rene's test with the 512 hertz tuning fork. I'll blow that, and then first I will place the stem over the mastoid process and instruct the patient when she should tell when the sound stops in the ear. And at that point, I'll take the fork to the ear. And if she can still hear that, that means the Rene is positive. That means ear conduction is better than the bone conduction. Cool. Then I'll check for the Weber's test, again, blowing the tuning fork and placing the stem in the center of the forehead, asking for which side she can listen better. Then I'll check for the vestibular component by asking the patient to stand at one point with the closed eyes and then march at the same point. I'll tell her that if she tend to fall, I'll catch her, so she should not worry about that. And then I'll check for the glossopharyngeal nerve and the vagus nerve by asking the patient to open the mouth, checking for any incoordination or dissymmetry of the palate and uvula. Okay, can you please present your case now? Today I've examined this girl who presented with roadside accident. She has bruises over face and is in a semi-comatose state. On my examination of the cranial nerves, she's Rene negative, and Weber is better hearing on the opposite side of the involvement of the ear. And there is also signs of head trauma, the base of the skull fracture, which are battle sign. And on otoscopy, there is blood in the tympanum. That's a hemotympanum is there. What would be the signs that you'll be looking for if a patient presents with bitemporal hemianopia? I'll check for the raised intracranial pressure signs, for example, headache, feeling of vomiting. Yes. And in bitemporal hemianopia, in the visual field, there'll be bitemporal loss of visual field. Yes. And that will be, it could be due to tumors at the optic chiasm. Very good. At the optic chiasm. Yes. And I'll also look for if it could be, in this case, of course, it is because of trauma, but normally, if it is because of some tumor, yes. Pituitary tumor, I'll check for the hormonal levels of growth hormone and prolactin also. Yes. Signs of prognathism and all these signs of. Then how should that patient be managed?
A patient with a pituitary tumor or yes.
Okay, so I'll first involve the multidisciplinary team,
Yes.
the neurosurgeon and the neuro-oncologist,
Yes.
and I'll begin with investigating the MRI,
Yes.
the
CT.
place of the
Yes.
tumor, and then
Yes.
CT
Yes.
could be used, but it's of lesser value, and
Good.
then removal of the tumor through transphenoidal approach, and stereotactic biopsy can also be done before that.
Very good. Okay. If a patient presents with conducting loss, what would be the presenting features? How would you confirm? Because
Firstly,
you
there'll
were
be
given
when I
otoscope
visit.
and tuning forks as well. Yes, please.
Yeah. So conductive loss can be due to hemotympanum or foreign body of Vex also.
Yes. Yes.
So with an otoscope, I can directly see that if any kind of those things are present. Then on whispering on that side, the patient may not be able to repeat that or may not understand the words. And Renee will be negative on that side.
Yes.
And Weber's test will be better on the opposite side.
Very good. Okay. Exactly on time. Good. Yes, please. Feedback. It was good. It was very impressive.
It
The
was
way
perfect.
you, yes,
Very well.
the way you carried yourself, it was very good. But yeah,
I think
maybe,
one
yes, yes, please.
maybe we can. It might be good practice to start off by saying that to complete my examination, I will do examination such and such of the
Exactly.
relevant nerve,
Yes,
Yeah.
examine the
yes,
cranial nerve 9 and 10, and with so and so test. Test in
yes,
a super form because we are not able to in time. And
yes,
cranial nerve
So rather
exam.
than doing all the nerves, should we focus on those specific only in the
exactly.
stem, or
This
I
was
was
also
gonna
I
ask
was
that
going to
because
say. Yes,
yeah, because
Mhm.
it says almost on a semi-comatose state. Obviously, we won't be able to do any of those tests
Mhm.
yes,
anyway.
but this is
I
like,
also thought so because,
yeah,
yeah, please continue, ma'am. I'd like to
because
know.
this was my scenario, but in the exam, this is a recall question, right? I showed you yesterday,
Yeah.
year examination came this time in 2020 October. So they only wanted 7 and 8 cranial nerve examination. So that's what you have to do. You have to read the question very carefully. If they want whole cranial examination, or they are just only focusing on particular ones.
So
True.
in this case, in this scenario, we should perform only the 7th and 8th nerve, ma'am.
Yeah. In particular,
Okay.
because
Yeah,
after hearing the feedback what I got from the members, they told me that it was ear examination. Exact scenario they cannot tell me, but then I have to make my own one. I got this one because here horse riding accidents happen a lot and we see them quite often. So this was more, and the young, mostly it's the girls game. uh, Boys are also there, but very few. So mostly girls get injured and they come and then we see them, and that's why it was more appropriate for me to have this ear trauma.
And
This was
also
Do
in
you,
trauma.
general
do,
examination, sorry, ma'am, but in this case, do we mention in general examination that to check for
He did.
signs of basal
He
skull fracture,
yes.
battle sign and
He
raccoon eye
continued.
sign or
Yes,
something
he
like that?
mentioned. He mentioned, and in a very nice
Yeah, no,
way.
no, he did mention. I'm just
He
asking.
did, yes.
Yeah, yeah.
Exactly in a summarized way, the way he has mentioned. That's how I would request you to mention. Like touch them, but don't go in details. He said he'll do Chris protocol, and then ensuring that, then he'll go on. He did it very in a very professional way. That's why I said the way he started, he gave his first impression, he marked his first impression, then he moved on. Okay, and then all right, he was in the beginning it was evident that he was confused if he should go through all the cranial nerves, but then he carried on. He went
yeah.
through all the cranial nerves and then he, okay. But at the end, when I asked him to, examiner may not ask you, Bell will go and they will see how you react. Would you keep on explaining the examination, or you'll stop and you'll summarize your case yourself? But then you have to be vigilant. Bell goes, drop everything and then say, okay, now I'll summarize my case for you. This is this. And then if time would have allowed you, I would have completed whatever was left.
Okay. Right.
Make sure you
That's a
do
good
that.
idea.
Yeah, because
For example, I
saying
missed the
is,
otoscopy in
yes,
this.
yeah,
saying
Yeah.
is doing.
sorry,
Mentioning, yes, please.
I'm a bit confused. In scenario like this, we
Yes, please.
are start with the ETLS, whole ETLS, or just
ATLS.
seeing
Yes.
a start examination.
Just
We can
finishing.
forget questions.
ATLS, yes, you can say
ATLS
ATLS.
protocol.
ATLS. Yeah,
ATLS,
it's ATLS.
because it's a trauma. Yes.
Yeah,
Yeah.
and
Thank you. Thank
It
you
should
for
be ATLS.
correcting. Even I'm sleeping.
yeah, and jump to examine the hearing and the cranial nerve related to that vestibulocochlear and facial. If there is any time, we can finish all cranial nerve examination. If there is no time, we just should complete examination of the ear from outside if there is any bleeding, or inside
Yeah.
by otoscope to see if there is rupture or hemotympanium.
Yeah.
So from your earlier experience, the feedbacks from previous fellows, do you know, Dr. Samin, how the question comes for all the cranial nerve examination? Or it comes in both ways. I mean, few cranial
It
nerves and
came,
some
yes,
stations with
yes.
both
Previously,
ways.
it used to come like in the all cranial nerves
Cranial nerves.
examination, but this time in particular they mentioned ear examination and the cranial nerves associated with the ear examination only. It was just
Yeah.
this one. And now
Ma'am,
Dr. Sunday has joined. Yes, please.
ma'am, would it be possible for this case just to make sure that we get like most of the points by starting off with the cranial nerve 7 or 8 exam, and then if there's still time, we'll go over the relevant cranial nerve exam that's doable for a semi-comatose patient?
I have made it semi-comatose. It will not be because in the examination
Mm.
patient has a cranial tumor. So it's most likely either it's anterior fossa tumor or the posterior fossa tumor. So mostly it's the tumors that the patient comes with, and it will be old patient, and scenario will be different. But one thing that they all told me that it was ear examination. Now I think we have Dr. Sunday. He can tell you more better because that's how member came and they gave me recall. So from recall, I realized, okay, ear examination was asked. So I created my own scenario, which may not be
Okay,
what comes in the exam, you understand?
thank you.
So
This
Dr. Sunday, yes, yes.
semi-comatose state, this term actually confused me in the beginning, because if the patient is in semi-comatose, I just
I couldn't
thought,
make
should we
the
continue the
patient
examination?
comatose and then make you do the examination,
I think
Yeah, sure.
I think right now they're overanalyzing the situation here. What you wanted him to do was just to do the cranial nerves.
Yes.
She just gave you a scenario, but for you to just examine the cranial nerves. That's all.
Yeah.
Dr. Sunday, good evening.
Good evening.
Yes, please throw some light on the recalls, how they asked you, what if you can remember the question for ear examination, how it was structured.
No, I didn't do ear examination. So
No,
mine was,
someone, yes, if you remember how they told.
I think you have to just do 7 and 8.
Yes.
Then, of course, do check for both tonic that's what do you call it? Tonic fork test. So both Weber test and Gordon
Clinical
test.
test, yes.
Yeah. So then the whisper test. And if you have time, you have to probably do other cranial nerve. Maybe that's associated with the hearing or so. I think that is just about that with trauma, because the patient with trauma, right? And
Yes.
maybe with sign of with maybe a battle sign, that's at master area. So those are the one. For the other cranial, the one I did was the patient that came with a visual disturbance. So you ask to examine the patient. So basically, you have to do from at least 1 to 7 is okay. 1 to 6 is okay.
8
But if you
even.
have time, you can continue until you have been stopped. Then you then complete examination by completing the rest of the cranial nerve examination. Even with you have to complete the examination by examining the rest of the cranial nerve. Then, if it is a patient that has a sign of anterior cranial fossa tumor, so I think you focus more on the cranial nerve, maybe 1 to 7 or 8 if you can.
Yes.
Then make sure that you do ATMTS test, that's abbreviated from mental test score, so which is very important for patient with anterior cranial fossa tumor. Then patient with a posterior cranial fossa tumor, it's more about cerebellar examination. So the scenario will be more about patient that is losing balance, so that you have to just examine. So I think based on the scenario, they will probably narrow. Of course, I think before they normally probably narrow the cranial nerve to examine, focus on. Then if you have time, you can proceed. I mean, you don't have to stop. You can proceed you can do as many cranial nerve as possible within the time given. Then the one that you cannot do, then you just tell them you would like to complete the examination by just examining the rest of the cranial nerve. I think that's just the major difference regarding the scenarios.
Yeah. Good. Thank you so much.
Then one more thing about the head trauma. So they also ask you to maybe describe the tympanic membrane.
Yes.
What you can see. Yeah.
Yes.
So
they
the
did
otoscopy.
ask the question. So what do you see?
Are you asking me?
Yes, I'm
The
asking them.
hemotympanum.
Yes.
Okay.
It's the otoscopic picture
Yes.
of hemotympanum.
Yes.
It's a blood.
So of which ear?
The
They
tympanic.
in particular ask you by looking at the image, how would you confirm from which ear this image has been taken?
Looks like the
It's with
left
the
ear.
umbo, yes. But then how you came to know? You have to justify your answer.
Oh yeah.
The cone of light, man.
Sorry?
The short process, the
The-
malleus will be in the suprolateral aspect, and the
Yes.
cone of light should be in the supro-inferior aspect as well.
Yes.
And the malleus will be angulated in a diagonal manner.
Yes.
This is the left side.
This is the left side. So you have to remember the features and you have to justify your choice, justify your answer.
This is the left side.
Yes, please.
Yeah, if they can.
But they could have right side as well. Then you have to know the difference, where the cone of light will be and how you will differentiate between the both sides.
Usually in 4 o'clock position. So this is on the left side. So this is in the 8 o'clock position.
Yes.
We are not getting you.
The cone of light will be somewhere in the 4 o'clock position on the respective side. So this is on the left side. If you look at it on a clockwise.
Okay.
Well, this is actually on 8 o'clock. Antro-inferiorly. It will be pointing antro-inferiorly.
Okay.
Yeah. Yeah, good. Thank you, Dr. Sunday. This in particular, they did ask. Yes. And we have Dr. Vaji as well. Do you remember, Dr. Vaji, any question when they were telling us about the recalls? She.
So,
Yes.
sorry, I wasn't there from the beginning, so I don't really know where we are.
About the ear examination, when they came and they were telling us about the recalls, do you remember any question about the ear examination that I have missed or we have missed in our discussion? We can just add.
No, I think we covered everything. I can't remember anything else.
Thank you. Okay, should we move on? Recording. And here is your timer has started and here is your question.
Okay, should I proceed, ma'am?
Just a second. Okay. If you have read and understood, kindly begin your examination session.
Okay, so first of all, I'll greet the patient and know his name and age and
First, you'll
introduce
wash your
myself.
hands. Yes.
Yes, sorry. First, I'll wash my hands and introduce myself and get to know the name and age of the patient and
Good.
to confirm that it's the same patient. And then I'll explain to the patient that today I'm going to do examination of your neck and it will involve me looking and feeling from the front and back side of your neck and over to the right side from where you are having a lump. And this will not be painful. If you are having any pain, please tell me now.
Good.
And do you
Yes.
understand and are you comfortable with the examination? And then after gaining consent of the patient, I will ask him to to expose and to open up the shirt buttons and and reposition the patient away from the wall, and the patient will be in a sitting position.
Very good. Very good. Yes.
So I'll proceed with the inspection of the patient from the front and on the front, back side, and from both sides, from the disease side as well as the normal side. And I'll ask the patient, where do you feel the lump? After that,
What would you
I'll on
inspect? What
inspection,
would you see on
on
inspection?
yes, on inspection, I look for the site, size, shape, symmetry,
Yes.
and look for the overlying skin changes and
Yes.
if there are any associated scar marks with the swelling.
Very good. And you'll see the both
Additionally,
sides.
I'll see the opposite side
Very good.
for any similar complaints, and I'll see the neck for any lymphadenopathies.
Very good. Yes.
And I'll ask the patient and I'll do clinical examination of facial nerve
Good.
by asking the patient to look up towards the ceiling and closing his eyes against resistance, blowing up his mouth, and to show me his teeth and to fan out his neck muscles. In this way, I'll examine his facial nerve. Then I'll ask the patient to open up his mouth so I can have a look at his parotid duct. Location is opposite the second molar tooth. I'll take my torch, and see if there is any inflammation or pus extruding from the stencil duct. So after that, I'll ask the patient if he is having any pain because I'll feel the lump. And after initially, I'll check the temperature and
Yes.
the tenderness of the patient, and later on, I'll palpate the swelling first over the normal side. First, I'll palpate the normal side of the patient, and then I'll palpate the disease side. When I'm palpating, I'm looking for I'm feeling for the surface,
Yes.
edges, consistency of the swelling, and its fixity to overlying skin and the underlying structures.
Good.
And if there is any fluctuation, pulsatility or expansibility, and to look for any transillumination and reducibility of the swelling.
How would you
Additionally,
instruct the patient? Sorry, I'm interrupting. How would you instruct the
yes,
patient once you're
yes,
palpating the lump in the parotid region? How
uh,
would you instruct the patient to do?
I'll instruct the patient while palpating to clench his teeth
Very good.
to
Yes.
contract the masseter muscles, which will
Yes.
give me a good idea about the fixity of swelling to underlying structures.
Very good.
And further, I'll move next to examine his lymph nodes. First of all, examining the submental lymph nodes, submandibular, preauricular, postauricular, occipital, posterior cervical, anterior cervical group, supraclavicular, and the pretracheal group of lymph nodes. And next I'll move to examine his oral cavity. I'll
Yes.
ask the patient to open his mouth and I'll explain to him that I'm going to put a finger into his mouth to palpate his Tenson's duct and
Good.
ask him to keep his mouth open. And I'll palpate the duct for any presence of any stones and ask him and for presence of any stones or inflammation and milk the duct to extrude if there is any pus. And additionally, I would look for involvement of a deep lobe.
How would you do? How
And
would you do that?
by bimanual palpation, by
Yes.
bimanually palpating the parotid gland.
How would
My
you?
right,
How would you by manually palpate the patient with your empty hands or with gloves on?
my gloved finger will be in the mouth of the patient,
Yes, very
and the
good.
non-gloved finger will be outside the mouth and pushing the parotid into my gloved finger. In
Okay,
this way, I'll
outside
palpate.
where? Yes, please explain.
It's, my outside hand will be at his parotid region,
Good.
in parotid region, and pushing the swelling inwards.
Can you please present your case now?
Yes. Additionally, I would, if I had more time, I would have examined for the chorda tympani by asking for his taste sensations. And patient is a 56-year-old heavy smoker. He has complained of swelling in his right ear since 1 month, in front and below his right ear since 1 month. On examination, I have found a 3 into 4 centimeter swelling in the parotid region with no
Yes.
overlying skin discoloration or scar marks, however, and the swelling is firm in consistency with regular, well-defined margins, and it is non-pulsatile, non-transluminant, and it is not reducible.
Very good. So,
And
what was your differential diagnosis of the parotid lump?
my differential diagnosis are patient may be having a pleomorphic adenoma and or pleomorphic adenoma or Walthin's tumor and cyalolithiasis, or the patient may be suffering from Sjogren's syndrome and other, it may be a carcinoma too.
Okay, how would you manage this patient?
For this patient, I initially I'll take a complete history of this patient
Good.
and further examination,
Yes.
and after that I'll move with ultrasound scan and fine needle aspiration of the swelling to know the exact diagnosis of the swelling, if it is a benign, inflammatory, or a malignant tumor.
What investigation would be ideal if there was involvement of the facial nerve?
If there was involvement of facial nerve, I would go with the CT scan or MRI scan of this patient to
Very
look
good.
for deep lobe involvement and to look for involvement of
Perineural
blood
invasion.
vessels.
Yes. Very good. Okay. Thank you.
Thank you, ma'am.
It was good. First time you have done
Thank
it, and it was good. The first only one thing, considering it's corona pandemic going on, washing hands. Otherwise, you
Okay.
did even tell me what if time would have allowed you, what you would have might have done. So it's good, excellent. I'm happy.
Okay.
Yes,
Thank
please. Anyone else? And you kept yourself within the given time as well.
you. Oh, thank you.
Very good. Okay. Anyone else want to give feedback, please? If I've missed anything, because he did mention that he'll examine the both sides. So maybe he didn't give me much to. Yes. Thank you
He do
so
it
much.
perfectly, but my question in the scenario,
Yes.
he says the nerve, facial nerve is non-involved.
Yes.
We should also again re-examine the facial nerve, or we should
Yeah, in
just
this scenario, okay, there was maybe no need, but still you have to confirm it. They have said it, but like in examination station, I don't know how the stem will be written. So considering that it can be involved, or maybe if it's involved, then yeah, so it's better to cover it. the way he has done it, because yes, it can be asked. This is
Uh,
like my scenario.
Another thing, we can examine the duct opening when we are massage the gland, if there is any secretion or discharge.
Yes, he did examine the duct opening.
Opening
He
of the duct
examined.
and
Yeah,
and
he
ma-
examined everything.
okay, yes, you do it perfectly. Thank you.
Yes, thank you. Yes, timer has started, and here is your question. You have read your question and you have understood. Kindly begin your examination now.
I'll first wash my hands. I'll introduce myself to the patient and I'll confirm the patient's name and age. And I'll explain to the patient that today I've been asked to examine a gland in your neck. This will involve me looking closely at the neck and the sides, and then basically touching and feeling the neck for the swelling and performing some tests. I'll ask the patient if he's okay with this. And once I've obtained the consent, I'll
Very
recheck
good.
with him if he's having any pain anywhere in his neck. Following that, I'll ask the patient to expose the top part of his neck. So I'll ask the patient to unbutton the first two buttons of his shirt
Yes.
and expose the neck for me to examine. And then I'll ask the patient to sit next to, sit for this
In front
examination.
of you, yes.
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 And on inspection, I'll actually look for the general status of the patient. I'll check if the patient is anxious or any agitation is, or any fidgety is present. Then I'll ask the patient to examine his hands. I'll check for the dorsum, dorsal and the plantar on the palmar aspect of the hand. Check for any palmar erythema, any dry skin. Then I'll ask the patient to lift up his hand and I'll place a paper on top of it to check for any tremors.
Very good.
Following that, I'll also rule out thyroid acrophagy by checking on the dorsal aspect of the palm. Then I will check for the pulsations to check for if there is any high heart rate or low heart rate, which is significant in thyroid disorders. Then I will move on to general inspection of the face to check for any dryness or any sweating if present, and if there's any loss of eyelid on the outer third of the eye, outer third of the eyelid. I would check for any exophthalmos. For this, I will inspect the patient from the front and from the side, and I'll ask the patient to extend his neck and so that I can visualize it from the back. If there is any obvious exophthalmos, I'll visualize that and document it. Then I'll look for lid lag. I'll ask the patient to follow my finger as I move it from above downwards and check for the lid lag if it's present as it moves along with the eye. Then I would move on to examination of the thyroid gland. So for this, I'll start inspecting by looking at the front for the any obvious swelling. If there is a swelling, as mentioned, I would check for the side, size, shape, extent, margins, and the lower border, and skin over the swelling, and movement with movement while asking the patient to swallow some water. And also, I'll ask the patient to protrude his tongue and check for movement with that. Followed by that, I'll move on to palpation. The palpation, I'll do it from the back, and I'll explain this to the patient that I'll be examining through both sides with my hand. I'll first feel for the thyroid prominence and go down to the isthmus of the thyroid and feel both sides of the gland. I'll check for the size, shape, symmetry of the gland. If there's any swelling, if the swelling is present, I'll check for the borders, the consistency, if there's any obvious palpable lymph nodes present as well. Um, Surface margins and skin over the of the swelling if it's pinchable or not. I would also check for any palpable thrill. Then I would come from the front and confirm that the trachea is central. I'll also do percussion over the sternum to check for any retrosternal extension. Following that, I'll actually auscultate for any obvious thyroid bruit. Then I would complete the examination with the help with checking the reflexes to check for any hyperreflexia in case of hypothyroidism. I would also check
Did
for
you ask the patient to swallow the water?
yes. Oh, while palpation, I'll ask the patient to swallow water as well and protrude the tongue so that I can visualize if the swelling is moving up on deglutition or tongue protrusion. I would confirm the margins with that to check for any lower border extension as well. Again, I'll kind of finalize the examination with the help of reflexes. I would check for any hyperreflexia. I would also check the lower limbs for any pretibial mixed edema,
Very
and I
good.
would also I would also rule out any proximal muscle myopathy by asking the patient to fold his arms over the chest and ask the patient to stand up from sitting position. Um,
Yes.
Thereby completing my examination. Following that, I will thank the patient and I'll wash my hands and I'll summarize my case. Um, Today, I have examined a 62-year-old
You
lady
still have
presenting
1 minute and 40 seconds. Actually, when you were inspecting, you could have asked the patient to drink the water first. And then the second time was after you were done with the palpation and you
No,
were
I
going
said
on with
during
the
inspection,
examination. Yes.
I forgot to say that.
Yes.
In inspection, I said that I will check with swallowing and with tongue protrusion.
Yes. Okay.
In
And lymph node examinations, you've done all.
I can explain. For the lymph node examinations, I will check for the submental, submandibular, then the preauricular, postauricular, and then the occipital, followed by the upper jugular digastric, middle, and the lower jugular digastric.
Yes.
Then I will wait for the lymph nodes on the anterior triangle, check for pretracheal and paratracheal lymph nodes, and then I'll go for the posterior triangle lymph nodes and the supra clavicular lymph nodes as well.
Did you remember to take the radial pulse?
Yes, I did. I
Okay.
did pulsations
All
after the
right. Okay. I'm
examinations
sorry.
were
All
done.
right. Then now you can present your case. Still you have 35 seconds, but still. Okay.
Um, yeah, so I will thank the patient. I'll wash my hands and I'll summarize my case, ma'am.
Yes. Yes, please.
So today I've examined a 62-year-old female presenting with a swelling in the neck since the past 8 months. On examination, I'll describe my findings. The swelling is diffusely enlarged swelling of the entire thyroid gland, which moves up on deglutition. And on palpation, the swelling, I'll describe the swelling as I feel on palpation.
Yes.
Uh, and I'll also describe if there's any extra additional lymphadenopathy present or not.
Yes.
And based on
So
findings,
what are your differential diagnoses?
my differential diagnosis mainly includes swelling arising from thyroid gland. Could be a simple goiter or multinodular goiter, or it could be secondary to a thyroid neoplasm, or if there are any toxic signs involved, I would also consider a toxic multinodular goiter.
Yes. So on examination, how big was the lump?
Uh, Findings
Yes.
are there, so
Not much, but how would you expect that to be? Because depending upon your differential diagnosis, you have to tell me something.
maybe a swelling
Was it?
of about I don't know, 5 into 6 centimeters.
Yeah.
It
How
says that
should
it's
this patient be managed?
so, ma'am. First, following my detailed examination, I would like to confirm the diagnosis. First, I would do an imaging study,
Yes.
where I'd like to do an ultrasound of the neck, followed by a fine needle
Use the
aspiration
word triple assessment.
or
Can you
triple
explain
assessment.
what that is?
Triple assessment. First, I will take a history and proper examination, followed by
Yes.
an imaging, which is
Yes.
basically ultrasound, followed by cytology, fine needle cytology to
Yes.
cells which are involved. So I need to get so I can get a histological diagnosis and then plan the management based on that, man.
Yes. So if you do the FNAC and after some time patient comes back with the difficulty of breathing, so how would you interpret that? How?
Ma'am, immediately
Yes.
or later on?
Yes. No. Immediately. What should be the management plan?
Immediately after FNAC, if the patient presents with difficulty in breathing, I would suspect a bleeding into the gland, a hematoma,
Okay.
or causing obstructive symptoms, or I mean, If it's a late onset, then I wouldn't suspect a malignant change over the swelling, or also
Okay, when the report comes back of FNAC and it says follicular cells tumor, unable to differentiate carcinoma from adenoma, why has this happened?
follicular carcinoma is differentiated by from adenoma by the potential to invade into surrounding structures, which cannot be appreciated on a cytology. So we
Yes.
need tissue biopsy. We need histology rather than just cytology.
So what would you advise the patient next?
We can either go for a true cut biopsy or a excision biopsy.
Okay. So if it's a follicular carcinoma, so how much is the 5-year survival rate?
Survival rate is more than 90% following completion
Yes.
complete thyroidectomy.
Good. Bell has gone. Yes. Feedback, please. It's good.
Okay.
Carotid palpation. Yes, he missed.
Carotid palpation. Yes.
Yes, Dr. Prabhajit, if you have to leave, you can leave. He has left, right?
I think no, he's here.
Yeah, he's here.
No, I'm still here. I'm still here.
Okay, if you
I
have
had
to
to
go, you
go,
have to
but I
go.
came back.
All right.
I'll do that.
Yes.
Did he auscultate the carotid or PROE on that?
Yeah. That I heard, yes, very carefully. One only thing, and then because there was still time for your examination, that's why I stopped you from summarizing your case and we discussed. I had confusion. I missed. Maybe I missed. I didn't hear you asking the patient to drink the water and you seeing
In palpation,
patient
I did mention
swallowing.
that.
Yeah.
In inspection, I did. In palpation, I mentioned that.
Yeah, that I missed because in thyroid examination
No, I
you have
didn't say
to
it.
do it
I
twice.
forgot to mention that.
Sorry. Yeah, I missed as well. Good. Anyone else want to give feedback? Yes, please. Yes.
Ma'am, I have a question. But first, that was an excellent job from
Yes.
Dr. Morali. Yeah.
Thank you.
Anyway,
Yes.
I have a question when it comes to the summarization of the case. Like,
Yes.
in terms of the physical examination findings, because there won't be any patient, right?
Yes.
So, what are how would summary go? I mean, how would we summarize the case if there's no physical exam findings?
There are certain favorite stems already given, right, in our traditional notes. So if you can just look at those notes and then you can have an enough idea that if in this case, if it's thyroid and if it's already old woman and it's follicular carcinoma most likely, then you have to say, okay, how big would because here it says she's otherwise healthy, so there are no obstruction symptoms, she's not having any difficulty. So thyroid lump, if there is any, it will be small, so you can just say the smallest palpable uh, thyroid swelling size, that on examination lump size was 1.5 into 2, just saying, for example. Okay. And then you can say there was no scar, overlying skin was not adherent, like you depending upon the scenario given, you have to create your own presentation, and then you have to, once you're examining or once you're explaining the patient, you have to keep 3 to 4 differential diagnoses in your mind as well. There is no false or correct answers in this one as well, but then they want to hear their own favorite terms, when like Dr. Siridat Morali was explaining or presenting his case, he presented it another way, and I asked him to tell me if he has heard of triple assessment, because these are the keywords that they want to hear, and these are the words on the basis of which they give you mark. So if he tells me management on the basis of triple assessment, he'll get a mark. And for you asked me presentation, so everything will be given in the stem. It will be more descriptive and more easy to follow than my questions or my stems. I promise you this.
Okay, ma'am. Thank you.
But then you have to. Yes, please. Yes, please. You can
I can add
answer.
one thing. Sometimes there is a positive clinical finding is given in
Yes,
the scenario, you can use it in presentation. And
yes,
sometimes the examiner, after you are finishing the exam, he tell you the patient, for example, patient nodular goiter, or give you any finding to help you to present your case.
yes.
Oh, okay.
It will be
Thank
given
you.
enough information for you in the stem outside, but then only 1 minute will be given to you. So you have to read it very carefully,
Okay.
not to miss
Yeah.
it.
I have a
Not to
question
miss
for
it.
you, mom, here.
Yes, please. Yes.
If the scenario like this, he said, examine the swelling in the neck.
Yes.
We can start from the neck and for the periphery, or start from the periphery like a sign and symptom of the thyroid abnormalities in the hand and eye, and go to the gland, because we didn't know firstly this is a thyroid or no.
Yes, it will be evident from the stem that it is thyroid examination that they want you to do. Yes, and then every person, every individual has his own routine or rituals that they have to follow to examine a patient, right? Not to miss anything, but it doesn't matter if you begin from the periphery or from the thyroid first and then move on to peripheries. But in whatever way you go, don't miss anything and make practice of it so that you cover everything.
Okay.
It was easier if patient would have been there, then yeah, but then I will request you, since there is no patient, so do the thyroid examination first and then move on to peripheries. And if time does not allow, then at the end you can just say, okay, if time would have allowed, I would have done this as well. But like it's better or it's easier to begin with the neck examination. So inspection and palpation and examination, that would be a lot more easier, in my opinion. Yes. Yes. Any more questions? Here is the question. Right? If you have read and understood, kindly begin your examination station.
Yes, I will wash my hand, introduce myself, take identity of the patient, explain what I'm going to do,
Yes.
and exposure of the patient, hold the area is of affected area,
And
back,
take the
and
consent.
yes, give a consent. I explain
Yes.
for the patient what I am going to do, examination, and explain for him what step of my examination. Look for the swelling, touch, and special test,
Yes.
and I will expose the patient his back and all area I suspected. I will see there is swelling, and comment on the swelling in general. For example,
Yes.
the back is with multiple swelling, and comment on the swelling, the smallest one about what size, and large one what size, and distribution of the swelling. For example, hold the back swelling, if there is any skin change, if there is any abnormality of like a scar, if there is any changing color, if there is any other swelling not on the back, like lymph node, axillary lymph node. And after that, I will going to palpate. I will examine two swelling, less one, smallest one, and big one. I will examine in detail for any temperature,
Yes.
any pain or painless, any tenderness.
Yes.
I will see the consistency I will see age of the swelling
Yes.
and skin overlying and
Yes.
attached to the underlying structure. I will also see transillumination after dimming the light of the room. I will also
Yes. Yes.
compressibility of there
Yes.
is any pulsatile.
Yes.
Also, I will listen.
Reducibility
Yes, reducibility.
and
I will,
fluctuation.
yeah.
Good.
I will also examine the drainage lymph node from this area.
How would you confirm the fluctuation of the lump?
By 2-planar or 3-planar or 4-planar, I touch the lump between two fingers and press in other 2 fingers and see the other fingers is pulsatile or no.
Yes.
Yes.
Then what are the regional lymph nodes that you're going to examine?
In the back, I will examine the posterior axillary lymph node. And
Axillary
if there,
lymph node. Okay. Yes.
yeah, axillary lymph node. If there is a swelling in the lower abdomen, I will examine also the inguinal lymph node.
Yes.
Other thing.
In what conditions would you expect lymph nodes to be swelled?
Axillary lymph node.
No, in what condition? When?
If there is infection of the swelling,
Yes.
or there is a malignant tumor and meets to the drainage lymph node.
Very good. Okay, what would you do next?
I will say tell the patient to tight the muscle of the back and try to mobile the swelling if it is attached to the underlying or
Yes.
no.
Yes.
Okay.
What else can be? Yes, you still have 2 minutes, so I want you to think if there is anything else we could add in the examination. So inspection and palpation, and then
Auscultation of this pulsatile
yes,
swelling
yes,
and percussion of the chest and examine of the chest. Maybe also lymphoma and metastasis of the chest. I should examine the chest also.
yes. Okay, can you present your
That's all
case
I
now?
think.
Yes. Can you please present your case now?
I examined. Yes, I examined the patient, young male patient with multiple swelling in his back. The smallest one is 1 by 1 centimeter, large one 3 by 2 centimeter.
Yes.
Is no change in the skin overlying it or not attached to underlying structure. Is not is soft, not compressible. There is no pulsatile or there is no any lymph node drain. Is most probably presented with multiple lymphomatosis or neurofibromatosis. I need to examine the chest. I need to examine other lymph node of the body, and yes.
So, what are your differential diagnosis?
Multiple lymphomatosis or
Okay.
neurofibromatosis.
What else would you consider?
There is a syndrome, I forget.
Could be that could be sebaceous cyst. It could be abscess. Could be soft tissue tumor.
Yeah.
Yes. Could be vascular
Yes.
malformation. All right. What should be the management?
Management after taking full history examination, I will investigate for do the lumps by do ultrasound and take a biopsy for a lumps, and
What type
I
of
will do.
biopsy is ideal for
I,
lipoma?
I will do excisional biopsy.
Okay.
I will do also chest X-ray.
Yes.
I will do MRI if there is any abnormalities of the brain. If this is a neurofibromatosis.
Yes.
I will consult the dermatologist.
Yes.
Yes, and management
And what
accordingly.
should be the treatment? Yes.
Treatment if lipomatosis, I will just observation and follow up. If there
Yes.
is a tumor, I will excise the whole tumor and lymph node drain if there is involved, and to consult multidisciplinary team.
Yes.
Yes.
And how often? What would be the advice you will give to the patient after excision has been done, or regarding follow-up?
If there is any change of the swelling or painful or change in the color, return back early.
Yes.
If we have any other swelling like an axillary lymph node or other area, we can return back early.
Good. Thank you so much. Excellent.
Thank you.
Yes.
Thank you.
Feedback? Anyone? It's excellent. Yes, we covered everything. In this kind of scenario, time is enough. Not much to say or do. Yes, Dr. Sunday.
Hello.
Yes. Good evening. Yes.
About everything. Good evening. But I noticed something. After the examination, he didn't wash his hand.
Yes.
Yes, I wash my hand. After
Afterwards.
examination, yes, I forget. Yes.
Yes.
Yeah,
And
yeah.
And
he didn't thank
from
the
beginning,
patient.
did you? Yeah. So did you position the patient? Did you mention the exposure?
Exposure
Yes, I
he
do
mentioned.
exposure. Yeah.
And
Okay. What
position.
about position of the patient? Hello.
Maybe not. Yes.
Yes, Dr. Sani.
Okay. So just then he didn't complete examination. So those are tiny little bits that carries,
Marks.
couple of
Yes.
marks.
Washing
Yeah.
hands and thanking the patient at
Because
the end.
the initial or wiper portion of our introduction, permission, or confirm to patient identity, then ask whether the patient is in pain, exposure, the position of the patient. Those carries mark, and at the end, wash your hand again, thanking the patient, probably offering to help to get the clothes, stuff like that. So they are all part of the professionalism and the communication. And they
Yes.
probably together we probably can get up to like 8 marks over 20. So regardless of whether the station goes well,
Very good.
we
Yes.
need to focus on those little marks.
Yes. Maybe
So
you can
that's just my
offer
own.
the patient, because patient is 55 years old. Maybe you can ask if they need help in dressing back up. So yes, and thanking and washing the hands. Yes.
Yes, I forget this. Yeah.
Yeah.
Thank you, Dr.
So
Sani.
thank you. Yeah. So now remember this for next time, because
Yeah.
time was enough. You were getting bored. Nothing was coming in your brain, and then yes, these were the things that missed. Yes. Good. Very good. Thank you, Dr. Sunday. Yes. Timer has started, and here is your question. Eight seconds. Right. If you have read and understood, kindly begin your examination station.
Okay. So first of all, I will wash my hands, introduce myself to the patient, and then
Yes.
also confirm the patient's information, and then I will explain the procedure to the patient, and
Yes.
then also take consent from the patient as well. If the patient already understands what I'm going to do, I'm going to explain that I'm going to examine her jaw to know what it is. But before doing that, I'll also ask the patient whether she has pain as it's stated in the question. So I
Yes.
have to elicit the patient and then empathize with the patient as well. So then I'll expose the patient the area by, if the patient is wearing a shirt, ask the patient to unbutton her shirt, and then
Yes.
or just drop it. So from there, I'll start by inspection. I will
Yes.
inspect the area. I will make sure that I ascertain the size, the shape, the symmetry, and then also the overlying skin, and then also if there is any associated scars. But I'll also do it on to the other side, the contralateral aspect of
Very
it
good.
as
Yes.
well. That's on the left side. Yes. And then also ask the patient to open her mouth, and then to examine the ducts, which are usually laying on the both side of the frenulum,
Yes.
on the lingual frenulum. So I'll ascertain that the ducts are fine, that they are not inflamed, that they are not discharging. Also, I'll ask the patient to show me her teeth, because maybe there's a facial nerve involvement. So ask her to show me her teeth, and then also check for the hypoglossal nerve as well, to ask the patient to remove her tongue, sorry, and then check if there will be any signs of tongue deviation. Then from
Good.
the inspection, I'll move on to the palpation. I'll explain to the patient while she is all this while she should be sitting by right. So
Yes.
now I'll go to her, yes, behind the patient. I'll explain to the patient that I'm going to touch her to palpate the lump. So I have to check the size of the lump, the surface of the lump, whether it's rough or it's nodular or it's smooth, the edges, whether they're regular or not, and then check the consistency, whether it's soft, hard, or or firm. So I have to
Yes.
also check whether it's attached to the underlying structure as well, whether it's fixed or not, and then also check whether it's pulsatile or not, to know if there is any arterial involvement, and also examine the ducts as well, to check if there is any tenderness, whether it's discharging. And then I move on to the lymph nodes, checking the submental, submandibular lymph nodes, preauricular, postauricular, the
Yes.
supraclavicular lymph node, the cervical lymph nodes, and the occipital lymph nodes. And then also do a bimanual examination with gloves, putting 2 fingers inside, checking the Watting ducts on both sides, checking if they are draining, and then if they are tender or not. And also
Okay.
I'll check for the sensation of the tongue
Lingual. Yes.
on the anterior aspect of the, yeah, and then also palpate the contralateral aspect as well,
Good.
because you have to do the 2 sides. So, yeah, from there, and then I will wash my hands and then thank the patient.
Yes. Still have 1 minute and 50 seconds. Right. In this one, in these scenarios, when you have to go behind the patient and examine, here you have to take or
Yes.
especially mention that I'll take the consent, or I'll explain the patient as well that for the purpose of my examination, I have to go behind the
Okay.
patient.
Okay.
And yeah, so this you should also
Okay.
add.
Yeah. Okay.
Yes.
Okay.
Okay. All right. If you can present your case now.
So I present a 32-year-old female that presented with painful swelling on her right jaw
Yes.
for 2 months. So on examination, there was a swelling on the right side of the jaw, measuring about 2 by 4 cm, which was tender. It was soft. It was with regular edges, and then it was not fixed to the underlying structure.
Okay. How big was approximately the gland or the swelling?
The swelling, I said it was about approximately, I said 2 by 4 cm.
Yeah, okay. And there was no associated lymphadenopathy?
Yes, there was
Or
no
was
associated
saliva was
lymphadenopathy.
clear in oral cavity as you examined?
Yes.
Okay. And what was your
Yes, saliva
differential
was clear.
diagnosis? What was your differential diagnosis?
So it might be a ciliolithiasis,
Silo,
means
yes,
stones,
yes.
or yes, yes.
What else could there be?
Okay,
Because
it could
differential
be
diagnosis should be 3 or 4, yes. Yes, please.
it could be a neoplasm, which is
Yes.
unlikely, but
Could,
because there is no apparent history of weight loss,
yes.
it could also be an infection.
Dental infection.
Yeah,
Because of that, there could be swelling as well.
sure,
So
yes.
how should this patient be managed?
So I will manage this patient starting with the CRISP protocol, because this patient is in pain actually. She has a painful swelling. Can I manage like that, or I should just go to the investigation?
Yes, tell me investigation. Not, don't go in that because it's not
Okay,
that.
so
Yeah.
yes.
So
First of all, do the basics for her. I
how
can
would you
do
confirm your
the full
diagnosis?
blood
Because you
count.
said there could be silolithiasis. So how would you confirm your diagnosis? Sorry, I got disconnected. Can you
Okay.
please, yes, can you please tell
Yes.
me how
So
would you
yes. So
confirm
because
your diagnosis?
yes, I will confirm by ciliarogram of the how do you call it, of the salivary gland, or
Salivary
I can do an
stone, yes,
ultrasound. Yeah.
yes. So if you suspect it to be a neoplasm, how would you go ahead then?
I would do FNA, fine
Yes,
needle aspiration of
yes.
the gland, and then I
So
can also.
what are the treatment options available for this patient that you can offer
So
her?
so you can start with conservative management for
Very
her.
good. Yes,
Yeah, so I'll give her analgesia as she's in pain, and then I'll start managing her on antibiotics, and
yes.
then make sure that she's well hydrated, and then also has a gland massage as well.
Very good. How would you do that?
I think they just massage the gland
Okay, what is
manually.
salidoscopy?
I think it's a scope into the to the duct to
Yes,
see, yeah,
to
what's
retrieve stones.
the stones, yes, for the retrieval of the stones.
Yes, and if it's neoplasm, so then there'll be submandibular gland excision.
Gland excision, yes.
Very good. Okay. Yes, feedback. At the end, she thanked the patient. Yes, thanked the patient and she washed her hands as well.
Because they said it before.
Yes, so now you remembered. So, is there anything else that she has missed or forgotten?
You people critique, because I know I'm coming to take the exam, so you have to critique me. Well.
Yes, positive or negative feedback is very important because it
Yes,
will
it's
help you
important.
to yes, to prepare
Mhm,
better. Yes,
mhm.
Dr. Zed, do you want to add anything?
I think she missed to say it. I will examine the lymph node from the posterior, from the back.
Yeah, that
It's
I
just
told
I will
her.
examine the lymph node without self
Mhm.
examiner from it. Other thing
Okay.
she didn't say. I will ask the patient to stick his tongue in the roof of mouth to tense the floor of the mouth to touch the swelling. It's
Okay.
helpful.
Aha, okay.
Okay. Okay.
Yeah.
All right,
Yeah,
okay.
you're right.
Very good, all right, okay.
Thank you. Yeah. Mm.
And if you find the swelling, try to roll it out on the lower jaw to differentiate it from the lymph node.
Okay.
Good, yes.
Okay.
Very
Yeah.
good, thank you.
Thank
Yes,
you. Yeah.
yes. Good, thanks.
Okay. That was good.
Okay, timer has started, and here is your question.
Send it. Okay.
Yes, its timer has begun.
شنو ممكن يعطوني؟
Right. If you have read and understood, kindly begin
Yes.
your examination.
I'll wash my hand.
Yes.
I'll introduce myself. I'll confirm patient identity.
Yes.
Then I will take permission and I will explain the procedure that included observing the patient while standing, watching the patient walk down the hall and come back and backward. Then also I would like to examine the back by feeling the back, asking the patient to move the back, bending, and also moving the legs and also feeling the legs. Then I will ask the patient whether the patient is in any pain at the moment. If it is, I will have to sympathize and probably offer analgesia. Then I will now talk about the exposure. I will need the patient to remove everything. So I will remove all the clothing, leaving just an underwear, other pants, to be precise, so I can see the lower limb and the body. So I will proceed to inspection while standing. So I will observe the patient from the side, from the back, from the front, looking for any form of deformity, whether facial deformity, or scoliosis, or kyphosis, or lordosis, or the spine. Then after that, I will ask the patient to walk down while observing the gait. So then I also ask the patient if the patient can walk on tiptoe and on heel. Then after that, I will ask the patient to stand. Then I will then proceed to the to the spine by palpating along the standard process or from the cervical vertebrae down to the sacrum. Then I'll be observing for any pain. Then I'll ask the patient that if he feels any pain at the moment, please you should just tell me because I have to stop or take it gentle. Then I will palpate the muscles close to the spine, also on both sides, looking at the patient. Then after that, I will now ask the patient to move the spine. But since the patient is having pain at the lower back, so I'll be concentrating more on the lower back. So that's the lumbar spine. So I want the patient to bend over to the front, bend over, then the patient try to bend posteriorly. I will assure the patient that I will be there to help the patient should in case the patient wants to fall. The other patient to also bend to the side and bend to the side. The other patient to rotate while folding the arms. So, so I'll check for flexion, extension, side flexion, and the rotation of lumbar spine, observing for restriction of movement and pain in any movement. Then after that, I will explain to the patient that I would like to mark the back and check for special tests. So then I will mark with ruler and pen. So I will look for a point along the spinal crest. Then I will mark 10 centimeters above the point along the spine. Then I will mark 5 centimeters below. Then I want the patient to bend down. Then I will mark the 2 points, which is previously 15 centimeters. Then I will check the new the new length, which should be above 20 in long. Then after that, I will have the patient to go and lie down on the couch, on the bed. So while lying down supine, so first I would like to do femoral, sciatic stretch test. So I would like the patient to relax. Then I will flex the hip while extending the knee joint. Then raising the leg, checking for the level at which the patient feels pain, starting from the normal side, then going to the abnormal side. Then I will, after doing that, after getting the ankle, then I will also flex the ankle. That's to stimulate the ankle on the side to stimulate the sciatic stretch test. Then after that, I will quickly start the lower limb neurological examination by checking for the tones, rolling the leg, checking for whether the distal leg is lagging or not, or it moves together. Then I will keep dropping the leg to see whether there's angle at the popliteal fossa, that's below the knee joint. Then I will also check the tone for the ankle joints by making rapid movement and stopping to check for clonus of the muscle. Then after
How
that,
would you confirm the clonus?
I will make rapid movement and make a sudden dorsiflexion. So I have to feel the clonus movement of the muscles. Then after that, I will then quickly assess the sensation and for pain and touch. So using cotton wool and a neuro tip. So I will assess all the levels from L2 down to S2. So which will be L2 over the thigh superiorly, L3 lower anterior to the thigh, that's inferiorly, then over the knee joint, then L4, that's over the knee joint and the middle part of the foreleg, then L5 will be the first web space or the dorsal part, then S1 will be on the lateral side of the foot. Then then after that, I will also check for the same part for pain using a neuro tip. I will compare both sides. Always start from the normal side. Then after that, I will check for the reflex. So checking for ankle reflex and also knee jack reflex. So also comparing both sides. Then after that, I will ask patient to lie on the tummy. Then I will perform a femoral strength test. So by flexing the knee joint and extending the hip joint. So if there's any pain, that was be positive for femoral nerve strapping. So if after completing that, so I will thank the patient, I will wash my hand, and I would like to complete my examination by performing a complete universal examination of lower limb and also complete the examination of all the cervical and the thoracic vertebra. So today I have examined a 40-year-old who waitress, so who presented to surgical outdoor with complaint of acute chronic low back pain that related to the low back to the leg of the left. So on the examination, there's no obvious deformity. However, the patient was in pain, so which was mild in the low back. Then on movement, I noticed that the patient was having difficulty, the kind of lethargic gait. So and also while walking on the tiptoe, so the patient was really unable to walk on the heel. So then on the examination of the spine, patient has a tenderness over the lower back, then which mostly on the left side.
For which
and the
diagnosis?
patient has a loss of sensation along the L5 S1 route on the lower limb and all the sensation of that examination were normal. So based on my findings, my most different diagnosis will be nerve fluid compression of L5 S1 due to sorry, please, intervertebral disc herniation.
How would you confirm? Yes, how would you confirm your diagnosis?
Yeah, I would like to do magnetic imaging of the spine to rule out, to confirm my diagnosis. Also, I would also like to do peripheral nerve conduction studies to rule out any other possible cause of a nerve damage, like a diabetic neuropathy peripheral. So I would also like to do blood tests to rule out diabetes and other causes. I also like to do angiogram to rule out the spinal to rule out any other vascular cause of injury.
So what should be the treatment of this patient?
So for treatment, first I have to start with the pain medication, start going along according to the picture stages ladder, start with the simple pain medication. Then if that does not help, then we can do simple massage or with the physiotherapist. If all those fail, then we can proceed to surgical decompression.
Okay, so it should be disectomy or laminectomy or
laminectomy.
conservative. Yes. Okay, good. should or should not chaperone be asked for
Yes,
this patient?
chaperone should be asked.
Yes.
Yeah,
Okay.
I forgot. I remember later, but chaperone should be asked.
Yes. Okay. Good. 9 seconds are left. All right. Good. Yes. Good. Feedback, please. Was there anything that you left that you could have said that I want to? Yes, or you did say it afterwards. You wanted to complete your examination date.
I said it. So just to perform
Yes.
the examination and also to complete the cervical and the thoracic vertebra examination because I didn't do that because of time. If I done that, I won't probably make it up with time.
Yes. Good. Yes. Anyone else want to give feedback to Dr. Sunday?
So good.
Yes.
Ma'am,
Yes, please.
so Dr. Sunday, I think it's well organized, except for one, wherein you did the palpation of the spinal area before the assessment of the patient's gait.
Okay. Yes.
Palpation of what?
Done.
Of the spine area?
Yeah.
Before
Palpation
what?
first for the assessment of the pain.
Oh, for the assessment of the pain. No, I said before I started, I asked the patient if the patient is in any pain. So then, while palpating the spine area, I have to look at the patient's face to assess for pain.
Yeah, he said you should check for the gait first. I think that's what
The
he
gait
meant,
what?
right?
Yeah, I mean, you did the palpation first before the assessment
Inspection
of the patient's gait.
before the.
Oh, this pain, yeah. No, the first time I assessed the pain, I asked the patient before starting any examination. That was the first time I assessed the pain. Then I reassessed the pain while palpating.
Yes, he wanted you to start with inspection before doing your palpation.
Of course, I started
to
with
evaluate
inspection.
the pain. Yes.
Yeah, I started with inspection first. What I did is I asked the patient if the patient is in any pain at the moment. So before starting
No, I mean,
so,
Dr. Sunday, not the pain, the gait.
The gait.
Oh, the gait. Okay,
Yeah.
okay. Sorry. Okay.
Good. Thank you. Anyone else want to give feedback? Dr. Zed, maybe?
No, we do it perfectly. Really.
Yes.
Thank you, Sandy.
Thank you. Thank you.